Welcome to the EAU podcasts. In this episode, UROONCO Bladder Cancer Chief Editor Dr. Pradere talks to Associate Professor Andrea Necchi on the SunRISe-4 trial results.
Dear friends, dear colleagues, it's my pleasure today at ESMO 2024 in Barcelona to have Professor Necchi from San Raffaele Hospital, Milan, with us. We have been really interested by the release of the first interim analysis of SunRISe-4 that you presented today. Could you tell us a bit about the rationale behind the study and the design of it? Thank you very much for being with us.
It's a pleasure to be here, and I'm very glad to be here at ESMO 24 presenting the results of the interim analysis of SunRISe-4. SunRISe-4 is a study that is addressed to patients with a diagnosis of clinical T2, T4, N0, M0 muscle-invasive bladder cancer who are ineligible for or who refused to receive neoadjuvant cisplatin-based chemotherapy. So clearly, we have an unmet medical need for this population. That is actually representing the 50% of the patients who are diagnosed with MIBC and who have still a poor prognosis with a radical cystectomy up front. The SunRISe-4 study is a randomized phase 2 study with the aim of evaluating the contribution of two drugs, TAR-200, which is a gemcitabine releasing intravesical system, which is released through an osmotic system from a silicone tube that is easily put into the bladder via a catheter with an outpatient procedure, and combined with cetrelimab, which is an anti-PD-1 checkpoint inhibitor, or versus the cetrelimab monotherapy. So the study is a randomized study, but actually it is not a comparative study. So the population the patients were allocated in two arms, the combination therapy arm in cohort 1 or in cetrelimab monotherapy arm in cohort 2. But these are conceived as the two parallel arms without any aim of comparing the result. The study is not powered, it is not aimed to compare the outcomes. Patients were included having an MIBC diagnosis with pure or predominant urothelial carcinoma histology, and were refusing or ineligible for neoadjuvant cisplatin chemotherapy. And there were two important stratification factors represented by the completeness of the TURBT prior to start the neoadjuvant therapy and the clinical stage. The primary endpoint of the study was a pathological complete response, defined as lack of any viable residual disease at the time of radical cystectomy. So a very stringent definition of pathological complete response as compared to other similar studies. And of course, there are secondary endpoints represented by the rate of downstaging to non-muscle invasive disease, relapse-free survival, overall survival, and safety endpoints.
Yeah, thank you very much, Andrea. And I think it's also really interesting because for the first time we have data regarding a drug that is immediately delivered into the bladder in muscle-invasive bladder cancer, which was not proposed before, to have like a localized neoadjuvant treatment on top of the IV drug. So basically, we know that the patients that are selected cis unfit or ineligible and refusing platins. What were the main results that we have to take from the study? At the interim analysis, I mean.
Yeah, the primary endpoint results in the efficacy evaluable population, including all patients included with T2, T4, and 0M0 MIBC, provided a pathological complete response rate in cohort 1 with a combination therapy of 42%. The pathological downstage into non-muscle invasive disease rise to 60%, so quite compelling. And in the same results in cohort 2 with the cetrelimab monotherapy were 23% path CR rate and 36% path OR, so downstage into non-muscle invasive disease. So apparently inferior outcome as compared to combination therapy.
Yeah. As far as a comparison between the two cohorts, but still we see that cetrelimab looks to be less effective as a combination with TAR-200 that brings much higher complete response rate so far.
Yeah, this is a point for sure that should be investigated further with the continuous enrollment of the study. We will see what the final data will look like from this study. It's very premature to make any conclusion regarding the rate of CR or pathologic major responses with checkpoint inhibition. We have a heterogeneity of the patient population across studies. We have still a limited sample size. And we do have data from SunRISe-1 in non-muscle invasive disease that are providing similar clinical complete response rate from cetrelimab monotherapy as compared to many other immune checkpoint inhibitors. So overall, I think it's very early to say, okay, cetrelimab is inactive in this patient population.
Thank you very much. There are two other points that I really liked in your presentation. First of all, is the dose effects of TAR-200. As you presented, that the more doses that were received, the better was the complete response, meaning that there is probably also, with this kind of delivery system, an impact on the remnants of the response. It takes time to make a good response with this drug. And the other point is regarding T2 patient, because you compared it was stratified by T stage, and we saw better response in T2 patients with nearly 68% of overall response, not complete response, but overall one. Do you think there is a room potentially to discuss later in the future some consolidation treatment for these patients are highly responders to this kind of first neoadjuvant treatment?
Yeah, thank you. You made the two important points. So regarding the first point, that is about the completeness of the first point. I'm sorry, that is about the exposure, the association between TAR-200 exposure and pathological complete response. I think this perfectly highlights the need to have a learning curve by urologists, and to have urologists completely on board since the very beginning and being very well educated and instructed on how to best use, to best position and to best manage the treatment of TAR-200 in patient in an outpatient clinic basis. We see that in the majority of the patients that were the latest one enrolled, 32 patients that were able to receive the full course of 4 cycles of TAR-200, the pathological complete response rise to 50% as compared to 23% in those who have the possibility only to receive 1 or 2 courses. This is the point for sure that you have already mentioned. Regarding the second point, you are right. The data within the clinical T2 select population are pretty much outstanding, although very preliminary. But the possibility to rise the path CR rate to almost 50%, 48%, and the path OR, so pathological major responses up to 68% or almost 70% in this population, make this population is having very high chances of potentially be successful with this combination in further steps, in further studies.
Yeah, and I think it's also like paving the way to maybe further investigation for sparing strategy for this kind of patient that are highly, of course, selected, but have a good response locally, and with micrometastatic treatments added with the cetrelimab right now.
I completely agree. So the next step that the patients are asking to us to provide them with is the possibility to make a shift by removing the surgical part from this classical design and providing a cure and a potentially bladder-sparing cure in the patients by treating patients with intravesical and systemic therapy and re-TURBT or TURBT instead of cystectomy in these very selected patients. So this is likely the future for SunRISe, for the SunRISe platform, and I would say only for all the neoadjuvant studies that are testing effective therapies today. The next step is clearly questioning the role for surgery for radical cystectomy.
Yeah, thank you very much, Andrea. I think you raised this point, and as you said already, your patients are asking you to save the bladder, and I think the sparing strategies needs to really be understood and highlighted even for the urologists, because we are going to face more and more patients that will come to our consultation asking for alternative option to cystectomy, and this is what we are now seeing at the ESMO this year and probably in the next coming congresses with new adjuvant treatment that are giving hope for sparing strategies.
Thank you very much. I fully agree. This is the future, clearly. Thank you
Thank you, Andrea. Thank you.
Thank you for listening to this episode of EAU Podcasts. To keep up to date with bladder cancer developments, visit our educational platform UROONCO Bladder Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.